Hi, everyone, and welcome to another edition of NextGen MD. We have Dr. Lilly Johnston, vascular surgeon from San Diego, with us, and we are talking about a very important topic. It's not talked about enough, but it is talked about more these days than it was even in the past 2 to 3 years, because more and more pharmaceutical companies are getting involved. And it is, you might be wondering, LP little a. And it is a very big topic. It is at the heart of heart disease. It's at the heart of vascular disease. And Dr. Lilly Johnston is here to talk about why and what you need to know about it. So, Dr. Johnston, let's dive in. What exactly is lipoprotein, or A, or LP little a?
Yeah, lipoprotein A, affectionately known as lipoprotein little a, to distinguish it from the ApoA1 big A that's on our HDL particles. The LP little a is actually a subset of our LDL or ApoB particles, and it's a really bad actor. It is pretty much, our levels are genetically determined, and it has a significant, when it's elevated, a significant additional risk for cardiovascular disease like heart attack and stroke, but also valvular disease like aortic stenosis.
So whereas you have HDL and regular LDL, those ones have roles in the body. Does LP little a have any role in the body, or is it just one of those things that infiltrated over time?
We don't know for sure. We hypothesize because it has a similar affinity for plasminogen, which is one of our clotting molecules. And we wonder
Okay.
if perhaps sometime in the remote past, LP little a was a molecule that was advantageous to help us form clots so we didn't bleed to death. But if you turn that around in today's modern world, where we are less likely to be attacked by a tiger and more likely to have cardiovascular disease, clotting is not always our friend. And so one part of the increased risk conferred by LP little a is the fact that it prevents breakdown of blood clots. And so it causes some thrombogenicity or increased propensity for these acute events where we rupture a plaque, the clot forms and breaks off or blocks off our arteries, causing heart attack and stroke.
So for those who do have LP little a, if you are on safari, you're a little safer than most who don't.
We don't know. That's our hypothesis. But I think LP little a is, as you mentioned, really coming into the forefront. So again, it's a subset of our LDL particles, our ApoB particles, and it's measured separately though. And that's important because not everybody would know, based on a standard lipid panel, whether their LPA were elevated. And we know that it's about 20% of the population has elevated LP little a. So that's 1 in every 5 people.
Oh,
That's quite a bit.
so that is significant. And so you're saying that it's something, it seems that LP little a was something that we likely inherited from our parents or ancestors. It may be important at some point, but
Right. So
some
we all
have
have a
more
small
than
amount
others.
or a moderate amount or a large amount of LP little a floating around in our bloodstream. And the amount that we have is genetically determined.
And we just don't know yet why one person has more than others.
Correct.
And so why have we not heard about LP little a before, if it is so important?
Well, I think our understanding of the science behind lipid particles is really evolving. LPA has been on the scene for a number of years, but it's more nuanced. And up until recently, we didn't think there was much we could do about it. And so it has not been at the forefront of standard testing, and it is still not considered mandatory for everybody. It's does not, factor into any of the current risk calculators
Right.
where you would input your information and get a number for your risk of a heart attack in the next 10 years. So, but it's considered a risk modifying factor, which means if you have elevated levels, we might bump you up into the next category of risk, especially depending on how high those levels are, because risk does correlate with the degree of elevation.
And you mentioned that 20%. of the population seems to have LP little a. So coming in with, on some questions that we have, and quite a few questions that we have coming in from patients. This is a very big topic in our network at the Global P.A.D. Association. How do I know if I should be tested for LP little a?
So I and most others in the preventive space believe everybody should be tested at least once in their lifetime. Maybe twice because there's a small amount of variability. And if you're at a borderline level, testing a second time may provide some insight into which side of that line you fall on. But overall, I believe everybody should be tested at least once in their lifetime.
And I think you hit on this, that we're still learning so much, and so many doctors are still learning about this, and many may not want to test for LP little a because there isn't an actual drug on the market available to treat this in the way in which we're typically used to. You take a cholesterol pill, you take an injection at home. There isn't anything as easily and readily available for people with LP little a. So maybe there is some resistance. And this patient is saying, she doesn't understand why her doctor will not test for it. And, she believes that it should be included in a regular, as you said, cholesterol test on an annual basis.
Yeah, I want to say two things about that. The first is, even though we don't yet have a drug target that is commercially available for LP little a, for patients with really elevated levels and severe manifestations of heart disease, there actually is a treatment called plasmapheresis, where essentially, similar to dialysis, the blood is taken out of the body, filtered, and returned to the
Yeah.
body. And we can filter out those LPA particles for patients who are really suffering from the manifestations. And this is, a less than probably 1% of the people with elevated LP little a who need this. But just to be clear, for those who have the most severe manifestations of this risk factor, there actually is a solution that has been used to treat those patients. The second thing,
Lipoprotein,
the
right?
second thing is that just because we don't have a drug target for LP little a doesn't mean there's nothing we can do to lower your
Yeah.
risk. We all in the preventive cardiovascular space have agreed that if you have elevated LP little a, we would dramatically escalate our therapy for your overall ApoB particle number, right? Or your LDL-C cholesterol number, to reduce that so that we minimize the number of oxidized LDL particles. I'm getting mixed up here. The LP little a particle carries more of the oxidized or rusty lipids that really contribute to the formation and propagation of plaque. So those oxidized rusty lipids are the particularly dangerous ones, and LP little a carries extra of those. And if we can just reduce the overall burden of LDL-C and ApoB particles, then there's less of that stuff in general available to rust and build up. So when we have patients who have elevated LP little a, we are more aggressive about lowering the ApoB and lowering the LDL-C to mitigate that risk. So that typically means more aggressive lipid-lowering therapies like statins, PCSK9 inhibitors, ezetimibe, nutritional strategies, whatever is on the menu to lower ApoB. We would escalate those therapies in patients that we know have increased risk due to elevated LP little a.
And it's just interesting that you mentioned the liposorber, because I was reading a study that was done. It was actually just a case study from, I think it was USC, and it was a patient who had peripheral artery disease, the poor circulation in the legs, and they had no other option. The patient had wounds that weren't healing. The next step was going to be amputation, and they ended up using liposorber to just cycle out the LP little a, and his wounds healed, and he's still walking.
Wow.
I know. It was the only case that I've seen on that, but I thought that was really interesting. I met the team over at one of the conferences in June, and they were sharing that study with me. And I was like, bring me that patient. I want to talk to that patient and the doctor who did that, because there are a lot of different facilities that have it. But I find that a lot of the doctors, the vascular doctors, don't know that this is an option and that this machine is sitting in their own facility. It's there, it's available in so many facilities across the US, just people don't know about it. So Do you have one, do you know, over at Scripps?
So plasmapheresis, again, this is like a version of a dialysis machine.
Right.
We can probably do plasmapheresis for a patient. The question is, would insurance cover it? Can we convince everybody that this is necessary therapy? And can we get the patient a central line to be able to do this? I mean, it's a bit of a production to, it's not just putting an IV in and calling it a day. It's a big deal, and
Yeah.
we wouldn't be able to do that probably without, support from the hospital and from the insurance. However, if our only other alternative is amputation, I think it's a great solution to try and see if we can
Mhm.
get that done. And I'm really heartened that there's actually a P.A.D. case study. I hadn't known about that. So I absolutely want you to find that patient and that
Yeah.
physician and bring them on and spread that word.
That'd be great. You should co-host that one with me. That would be really great.
Let's do it.
That would be exciting. So I'm on it. Send you the study this week. Okay, so back to the patient questions. They have some very basic questions here. How is the LP little a test actually performed? I know the Family Heart Foundation has one that you can do at home, and when they have them in stock, they'll send it to you for free.
Oh, that's a great resource. I didn't know that. The other thing I would suggest for people whose physicians aren't comfortable ordering it would be to, if you live in a state where this is possible, go to something like ownyourlabs.com, where you can order this yourself. Go to your local LabCorp facility, get your blood drawn, and you can get those results done for you. And we can provide more information for that, but there are several of those companies. Own Your Labs is the one I'm most familiar with and like to support, but choose your own adventure on that one. It is possible in many states, but not all, to actually order your own testing and go get that done. It is a regular blood test, just like your lipid panel, and you should be fasting prior to getting that measured.
And another patient question, do you have to fast before doing this test?
I recommend fasting before getting any lipid testing done.
Okay, that's short and sweet, short and sweet. Um, oh, there were actually two questions on that, I think. How often should I have my LP little a levels checked?
So that's an interesting point. We don't yet, again, we don't have a specific drug target. There are certain medications that can lower LP little a bit. So for example, the injectable lipid lowering medications that we have discussed here previously, PCSK9 inhibitors like Repatha or Praluent, they can lower LP little a 20 to 30%, but we don't know whether that's clinically meaningful. Does that result in reduction in risk or adverse events? We don't know yet. So we don't typically recommend tracking the LP little a because it tends to vary within the range of low, it's always going to be low, moderate, it might go from 75 to 85 down to 50, but that's and again, I should step back here for a second. Be clear when you're looking at your LP little a measurements, if you have your own labs or you're getting it checked, there are two separate ways to measure this: the concentration or the total volume. So milligrams per deciliter is the less helpful measurement, but some labs still use it. The other is nanomoles per liter. And the reason that they are different is that the LPA molecule is actually different sizes in different people. So there is something called the Kringle 4 repeat, which you don't need to know about, but the size of the LPA molecule is different in different people, and that's also part of the hereditary component of this, is how many repeats you have and how big your LPA molecule is. So you can imagine if we're measuring the quantity of something that might be small in some people or large in others, it's the same problem we have with overall measuring cholesterol versus particles. So nanomoles per liter is a better option for measurement, but not everybody has it. But just get the same one done from time to time if you're getting multiple measurements so that you're comparing apples to apples. But we don't really recommend tracking it. It's going to vary within the same general bucket, low, medium, high, with our current therapies. So if you need to test twice to figure out which side of the is it high or is it not high line you are, fine. Otherwise, I don't necessarily recommend ongoing measurements because it doesn't change our management.
An interesting case. I got a call last week from one of our patients who has LP little a, an issue with it. It's weird to say I have LP little a. Everybody has LP little a, right? It's just a matter of how much, right? But she has elevated LP little a, and it was on the highest of highest ends for LP little a for the longest time. And she has recently gone on Ozempic in the past 3 to 4 months, had the LP little a retested, and it's now only moderately high. It was a dramatic decrease. And I know there's no scientific evidence yet. They haven't done a study, but that might be worth checking out because we're seeing remarkable results with Ozempic on so many fronts, whether it's smoking cessation, whether it's weight loss, whether it's diabetes, right? So many different, even with increases in walking distance because of the reduction in inflammation as part of its mechanism of action.
Yeah, I mean, reduced cardiovascular events. We have an indication for semaglutide in patients with cardiovascular disease now. And I actually was thinking about this as I was thinking back on our second part of our statin conversation, and what people are using to lower lipids, and looking at old research where we had things like niacin or fenofibrates, which just got an update in the labeling that lower our lipids but don't necessarily reduce risk. And what would I prefer? Would I prefer somebody go on a supplement that reduces their LDL-C but doesn't have any proven impact? Or would I rather they choose instead something like a GLP-1 receptor agonist that we know will reduce LDL-C somewhat, probably also LP(a), and has demonstrated reduced cardiovascular events? I mean, ultimately, that is really the target here. And I think there's just so much possibility in these new medications and this metabolic lens that we are viewing cardiovascular disease and risk through. Now, I know it's a prescription drug and it's very expensive, and there's a lot of baggage around that piece of it. And we can't ignore the fact that it has been very helpful in reducing so many different risk factors for our patients.
If I have a family member with high LP little a, should I be tested too?
Absolutely, yes. So every time we find somebody who has elevated LP(a), we recommend what is called cascade screening, which means direct relatives should also be screened to see whether they have been affected. So siblings and children are the typical next people to screen. Certainly, if your parents are still alive and young enough that it would be worthwhile and it would change their health care, by all means. But direct relatives should absolutely be screened.
We have one of our patients that has a 9-year-old that ended up getting screened and has it. It's elevated. And so there's nothing, the doctor was like, well, there's nothing I can do about it. I mean, it's there. You just have to watch it. And as she grows into adult, just make sure she eats right and exercises, and that's all we can do. And so hopefully we're learning more and more in the next few years. And we do have some new drugs that are being tested right now. And, it's the next step is going to be, well, should we and could we end up using them, on a younger generation of patients so that it can stall the progress of any damage that it would potentially do as they age. Because, right, plaque can start building up at any age, especially in your 20s.
Oh, absolutely. There is anatomic evidence that we have. This was originally, I believe, done in soldiers returning from the Vietnam War. So very young men who ended up expiring from not natural, but other non-cardiac causes. They examined the arterial wall and absolutely found early fatty streaks in the wall, which we believe eventually will turn into plaque if not if risk factors are not managed appropriately. So we know that the process of atherosclerosis begins early, and for people who have significant increased risk, whether that's due to elevated LP(a), familial hypercholesterolemia, or other genetic risks, we certainly can see very early plaque formation in the artery wall. And, I think it'll be a little more time before we have what you're referring to, which would be primary prevention data. So these would be all people with elevated LP(a), but no evidence of heart attack, stroke, or disease yet in the arteries. I think the first case will be those patients who've already had an event because it'll be easier to detect event rates in those patients because it's higher. So secondary prevention will probably be the first indication, but I am certain that primary prevention is on the docket and will be studied.
And I think you're going to be one of them on the front lines doing it. You probably already are, I would imagine, because you're all about prevention. You're all about pioneering new approaches to keeping people on their feet and keeping people alive. So what level a patient is asking of LP little a is considered actually dangerous?
So again, it depends a little bit on how you measure it. The cutoff typically in milligrams per deciliter is 50 milligrams per deciliter. And if we're talking about animals, then it's about 125. Each lab will have its own reference range, but give or take, those are the cutoffs.
Do we know yet, how much more LP little a puts you at risk versus other cholesterol numbers for heart attack,
So
stroke?
let's just talk about it independently. LP little a, it's proportional to the degree to which it is elevated, right? So you can imagine if we just talk about the animals, if your level is 126 and the cutoff is 125, it's elevated, but it is not wildly elevated above and beyond the reference range. So that's a moderate elevation that may represent up to a 50% increase in risk. So a 1.5 fold increase in risk of heart attack, stroke, or valvular disease, right? We talked about aortic stenosis or calcified stiff leaflets on your aortic valve causing issues. But once you're double the reference range, now we're talking maybe 3 to 4 times increased risk. And higher than that, again, even higher risk.
And can you have high LP little a when your other cholesterol numbers are normal?
Absolutely, you can, right? This is a genetically predetermined number, whether you're high, medium, or low, and your LP little a can be elevated even with a normal LDL-C. Now, it's probably less risky if everything else looks perfect, but it still does confer independent increased risk and should be measured and should be managed appropriately.
And these two questions were together, and just because this patient was really frustrated, and the doctor saying you have good cholesterol, but your LP little a is high, and that was why his um the doctor said that you likely have heart disease. He's like, oh, my other numbers are normal. I don't understand. Where did this LP little a come from?
Yeah.
So poor guy. Can you actually, are there any symptoms that go along with it aside from any cardiovascular symptoms? Someone wants to know if they have LP little a, do you start seeing symptoms? I mean, of course, with this 9-year-old, there's no obvious symptoms that they have an elevated LP little a. It's just as you age, right? It starts to do the damage.
Right. I mean, just like elevated cholesterol, there are really no symptoms associated with it. So you wouldn't know it other than getting it checked.
And Douglas, who's here in the live audience, wants to know, is there any relationship between LP little a and troponin levels?
Not unless your elevated LP little a has caused you to have a heart attack. So again, the troponin is a waste product or a marker of injury in the myocyte or the muscle cells of the heart. And troponin leaks out into the bloodstream when the heart is stressed or injured. And that is what you're measuring when you get a troponin level. But the LP little a is a lipoprotein that is floating around all the time and may increase the risk of you having an elevated troponin related to heart muscle damage if it progresses and plaque is formed and that plaque has damaged the heart. But otherwise, no, they're not related.
So if I already have heart disease, how does knowing my LP little a help? So if I'm already on cholesterol drugs, I know I have heart disease. Why is it important for me to actually get checked? Why is it important for me to know that I have that in particular?
One reason is to make sure that your physicians are also monitoring you for valve disease in the heart, so aortic stenosis. That can be detected with perhaps a murmur just using a stethoscope or an ultrasound test called an echocardiogram. But if you're developing shortness of breath or symptoms with exercise, for example, and you have heart disease, we need to know, is that plaque in the arteries or is that actually the problem with the valve? And you would be at increased risk for the valve problem. So that's one issue. And the second issue is people are on cholesterol lowering medications, but we actually have a target goal in mind for how low should we target your numbers. We will adjust your medications potentially based on how much risk we think you have. So if you have elevated LP little a and we know you have plaque, we may be even more aggressive in lowering your LDL targets.
Should I mention my LP little a to other specialists that I see? So my cardiologist tested me. I know I have it. Who needs to know about it?
If you have a vascular surgeon, they should probably know about it, but I don't know that your primary care doctor or your orthopedic surgeon particularly cares. So you're always welcome to mention it. It should probably be listed as one of your problems on your problem list, but it's not something that most of your other specialists, your endocrinologists or others, will particularly know what to do with.
And we've answered this in various different ways, but I like to, as you know, when a patient asks a question, I like to answer theirs directly. Do I need different care if I have both familial hypercholesterolemia and high LP little a?
I think you should engage with somebody who specializes in lipid management and who enjoys doing that. The average vascular surgeon or interventional cardiologist may not be monitoring things as closely as somebody who is, a preventive cardiologist or somebody who's really focused on these issues, especially in a primary prevention setting where you don't yet have evidence of disease. So if that's the case, then I would recommend getting in touch with somebody who, wants to be aggressive in managing these risk factors for you so you don't ever end up in this revolving door of procedures and operations and complications.
So this is an interesting question. Does menopause affect my LP little a levels?
It probably doesn't impact them dramatically. Again, the levels are typically genetically determined. It may impact it somewhat. What is interesting is that menopausal hormone therapy can actually reduce the LP little a levels a bit. And again, we're not sure whether that matters in terms of risk reduction, but that has been documented.
Should I be taking aspirin or other medications if I have LP little a aside from my cholesterol meds?
Great point. Again, this is an individual discussion you should have with your physician, of course, but there are some people who actually have a specific genetic piece of LP little a, which is itself a genetic thing, who respond proportionally better to aspirin. And that's a gene that can be tested for. I don't do that routinely in my practice, but I was just reading about it this morning, and there is a specific isoform of this that does actually respond disproportionately well to aspirin therapy for elevated LP little a and helping reduce events. So in general, if you have evidence of plaque in your arteries, a discussion of aspirin is warranted. And if you have elevated LP little a as part of the reason that has happened, then I think that's an excellent conversation to have with your physician and, review your bleeding risk and all of that. That would be the only downside to aspirin, or if you have a history of ulcers or GI issues, that would be the other concern. But in general, I do think that aspirin is a helpful tool for many, many people with plaque and with LP little a.
So what are the medications that are LP little a specific that are out there on the horizon? I know there's one by Eli Lilly. I know we talked about Liposorber being more like the dialysis unit that's more of a weekly thing for a certain amount of time. But general medications that you see on the horizon, aside from the general cholesterol meds, and including Repatha, which I've heard some doctors are telling me it works pretty well in doing some lowering of LP little a, but specific LP little a medications, what are we looking at?
Yeah, so we're going to be looking at several different types. They are all based on sort of the RNA expression, where the product is formed. So we have an antisense oligonucleotide, or an ASO, and that's pelacarsen. That's one that's currently in trials. And then we also have a separate category of molecules called small interfering RNAs, or siRNAs, and we have at least 3 drugs in that class: olpasiran, lepidisiran and zolacerin. I'm doing my best with those pronunciations. I don't have them down by rote yet. So those are the ones that are in trials yet for the small interfering RNAs, and early data show excellent reduction in Lp(a), upwards of 80 to 90% reduction in Lp(a) with these molecules, but we don't yet have information on what that has done for risk. So stay tuned. Those trial data are expected in the next year or two for the earlier molecules.
I would imagine you're going to a epidemiology conference coming up, and I would imagine you probably are going to have some late-breaking studies that are going to, or results, right, that are probably going to be discussed at that event.
I am heading to the National Lipid Association fall meeting right after we get off this call, and I'm super excited about that. I don't know whether we'll have late-breaking information on these. These actually are big enough big enough in the sense of impacting large numbers of patients that they may actually choose to present those trials at much larger conferences like the American Heart Association meeting or others. I don't know yet, but stay tuned. I will absolutely have updates from the NLA fall meeting when we talk next.
Yeah, there might be a little pre-release, some hints of some results, which all of our patients would be so excited about. But before we leave you here and send you on your way to get us even more information on this, so excited about that, I wanted to end on one of our favorite topics, which is diet and exercise. And there are several questions that came in about how much Lp(a) can be affected by potentially exercise and diet. And neither one of them can hurt. They can only help, right?
That's going to be my bottom line as well, Kim, which is that we don't think these particularly move the needle with Lp(a). I have seen some interesting N=1 events where profound inflammation, like illness, can actually drive up Lp(a), and that may change it. But overall, when we check it repeatedly, which again, I'm not necessarily recommending, but for the sake of science, some of us have monitored it over time in our patients. It sort of oscillates or hovers in this bucket that's low, it stays low, up or down a little bit, medium stays medium, up or down a little bit, or high stays high, up or down a little bit. And we never know, was it the exercise? Was it the diet? Was it better sleep? Was it the medications that we changed? Who knows what drives it up and down within that window? We do not believe that there is a significant role for exercise or diet in this particular risk factor. However, we know that is very significant in all of the other major metabolic risk factors that we talk about, and we never want to reduce a patient to a single lab value or one number. So, of course, we're going to recommend an excellent approach for nutrition and exercise for everybody, even though it may not move this particular needle in terms of your risk.
Thank you so much, Dr. Lilly Johnston at NextGen MD. Make sure you do like this video and subscribe to the channel and click the notification button for more great content like this. And you don't want to miss the updates from this lipidemia conference that I think we're going to be doing at the end of the month. So you don't want to miss our next NextGen MD with Dr. Lilly Johnston. So like and subscribe. Have a great week, everyone.
Bye, Kim.